So welcome back, guys. So today in this video, what I'll be discussing is the sagittal section of the CDPNS, how you can actually read a sagittal section. Now, why I'm doing this is because I got a lot of requests from people all over the world saying that they need to know and how you can understand the basics in reading a sagittal scan of the CDPNS. So what I'm going to do here, I've got a CDPNS of a patient and I'm going to show that CT scan in various orientations. So to understand the basic anatomy of how you can read the sagittal scan, you need to first understand how you read the coronal section. And once you do that, I'm going to compare these two in real time with each other. So wherever I show you or whatever I show you on the coronal section will be exactly in real time on the sagittal scan as well. So this is how the first thing you need to do to understand first is the coronal section. Once you do that, you compare the coronal with the sagittal orientation so that it becomes very easy for you to understand. So the first thing I'm going to do is I'm going to ask the radiologist before getting a CT scan done is I'm going to ask for a 1 mm CT scan, which is the best so far in practice. But even better than the 1 mm scan is the 0.5 to 0.6 mm scan because it gives a real detailed study of the anatomy. So a lot of doubt lies here in the thing that people get confused as to where to start from, which side is the left and which side is the right side in case of reading a sagittal CT scan. Now the first thing is that, as you can see on the coronal section over here, it is on the extreme left side over here, and as you can see, this becomes the patient's extreme left side on the sagittal scan. So the basic thing to remember, so if you get a copy of a CT scan, you won't be able to read this with the lines over here. So what you have to do is you have to locate for the auricle, that's the ear, the external ear, and it will look like something like this, the external ear, okay? So if you keep on going medially from the most lateral aspect, the first thing, the ear is going to disappear, and after that you will be able to see the bone, that's the temporal bone. That's quite common sense because if you're going from the lateral to the medial aspect, that is from outside to inside, the ear will come first, right? And then the temporal bone. So that suggests that this is definitely the left side of the patient. The same thing if I do and go to the extreme right side of the patient, what I will get over here is first the temporal bone. This is a temporal bone. To make it more clear, this is the mastoid region, and so far I cannot see the auricle up to here, okay? So what I can see over here so far is the mastoid bone over here, the temporal bone over here, and if I keep on going further laterally, this is the actual end stage of the temporal bone, the temporal plate, which you can see over here exactly on the coronal section. So that is the bone over here which I get, and further up ahead laterally I will start seeing my auricle over here. That's the patient's auricle, that's the external ear over here. So this is how you come to know that this is the patient's right side. Now many young surgeons confuse it over here whether which side is left and which side is right. So this is the first thing you need to do before reading any sagittal scan, because the radiologist may sometimes not mention the side of the lesion. Many times I've seen the report where they do not mention the side at which the lesion is present. They just mention that this lesion is so and so present in this sinus, in this area, but they don't mention the side sometimes. I don't know why. But so in that case, you need to be extra safe and have this knowledge to which side you are on the CT scan, okay? So that's the first thing you need to know and study in case of a reading a sagittal CT scan. Once we do that, if I can just come to the extreme left over here. So I'm starting from the most anterior aspect now. So I'm going to go to the most anterior aspect of the coronal section, and as you can see over here, I'm going to bring this sagittal to the level of the coronal section right here till the point where I see the frontal bone over here. So as you can see, my cursor is here almost touching the frontal bone, and I'm actually seeing the frontal bone on the coronal section as well. So you have to pay attention to both these scans to understand the sagittal section. So I'll start the reading of the sagittal section now. So to make it more clearer. Okay, so this is the exact orientation. Now that's the patient's center, or I can say the midline. Okay, this is the patient's midline. As you can compare over here, the patient, the axis on the coronal section is on the midline right now. So this will be a better understanding. So if we start from the frontal sinus, that is the frontal sinus, which you can see on the sagittal scan and on the coronal section. It's full of opacification with a lot of anaerobic gas shadows over here, which is suggesting that this patient was having a secondary bacterial infection within the sinus along with a collection in it. So that's the anterior table of the frontal sinus, which is made up of definitely the frontal bone, and which you can see over here. If I go behind over here, that's the exact level of the anterior table of frontal sinus, and you can see over here only the anterior table. So if I go behind over here, if I keep on going slightly behind, you can start seeing the perpendicular plate of the ethmoid over here and the nasal bone over here, which is exactly which you can see on the sagittal scan. That's the nasal bone, and you can see the perpendicular plate of the ethmoid at the yellow cursor right over here. So this is how you compare these two images. And now if I start going posteriorly, you can see the actual opacification of the frontal sinus, and which you can see over here as well. So keep on going posteriorly. If I keep on going posteriorly, I can still see the same anaerobic gas shadows on the coronal section, the same which I could see on the sagittal section as well. So I just have to keep on going posteriorly to make you understand this. Now this is the entire area of the frontal sinus, okay, because as I keep on saying this in my lectures, that so far as you can see the frontal floor, it is still the area of the frontal sinus. So as you can see over here, this is the area of the frontal floor. That means it is also called as the frontal beak. Now in my previous lecture of the Kuhn's classification of frontoethmoidal cells, I have made this very clear what exactly you mean by a frontal beak, how you can differentiate that with the frontal process of maxilla, and how the frontal beak forms the floor of the frontal sinus and a part of the anterior wall as well. So if so far you can see that the frontal floor is intact, that's the frontal beak over here, and so far you can call that as the frontal sinus. The moment you keep on going posteriorly, you will start seeing that the frontal floor starts to disappear in some time. As you can see over here on the right side, the frontal floor starts disappearing, but still on the left side, the frontal floor is intact where we are exactly. So if I shift on the sagittal scan towards the right side, which you can cross check on the coronal, the axis changes. So I'm coming on the patient's right side now, which you can well appreciate on the patient's coronal scan. Okay, so as you can see over here, now if I go on the coronal section back and come anteriorly, you can actually see that the floor is still intact. We could actually see the floor still over here. So this is still the frontal sinus area, but as we go behind, you can see that the floor disappears. Okay, the floor actually disappears. This was the floor was being intact, that is the frontal beak was still here. But now as we go posteriorly, that's the area of the frontal recess, and which the same thing you can see over here, that's the area of the frontal recess over here, and that's no longer the frontal sinus. So this is how you actually compare the area of the frontal sinus and the frontal recess over here, and that's the posterior table of the frontal sinus. You can actually start seeing the frontal lobe over here, and the same frontal lobe you can compare on this patient's coronal section. That's the frontal lobe. Now many young guys I've seen in my hospital where I used to work before, I used to see residents considering this as the frontal sinus sometimes, but no, that is not the frontal sinus. That is the frontal lobe of the brain actually. So everything seems to be of a same ISO intensity over here, the soft tissue density. So that's why a lot of times these people get confused. So this is a place where you need to differentiate between the frontal sinus and the frontal lobe of the brain. Now, this CT scan has a special variation in the anatomy of the frontal sinus, which I'll show you in some time. Now, till so far I showed you how to differentiate between the frontal sinus and the frontal recess on the sagittal scan. But there's something which you can see over here on the scan on the sagittal section. You can actually see a cell in the frontal sinus, okay, which is having an extra covering over here at the anterior table of the frontal sinus, but not so on the posterior table. So this is a presence of a extra cell which is present completely within the frontal sinus, but this is not the case of a type 4 Kuhn cell, but a frontal intersinus cell. Now we should know this for sure on the patient's coronal scan and then cross-check again on the patient's sagittal scan. Now if I come very much anteriorly on the patient's coronal scan, you can actually see if I start going behind, there's a huge single opacification in the frontal sinus. Now so far this is a huge cell, we cannot see any other cell so far, okay, and we can cross-check over here. It is one uniform cell without any interfrontal sinus septum. As we keep on going behind, we can start seeing the interfrontal sinus septum right here, which is more towards the right side. So if I shift my axis towards the right frontal, I can actually see that the right frontal is completely clear of the opacification because the coronal axis now is in the right frontal. The moment I come in the left frontal, I can start seeing the haziness over here, and that's actually the left side frontal sinus, but still we are not sure exactly which cell that is. So if we keep on going behind on the coronal section, you can start seeing that there's one more cell on the extreme lateral side of the frontal sinus, and if I show that same thing on the sagittal scan, you can start seeing this huge cell over here which is uniform and having the skull base attachment over here posteriorly, and you can actually see a separate bony margin anteriorly. So this is a huge cell having a posterior wall as the skull base. And if I keep on coming towards the most lateral aspect, I can actually see, as you can see over here, my axis, you can see a bony margin over here. That's very well shown over here. That's the bony margin, and that bony margin is nothing but the covering of the lateralmost cell. So if I can just bring that on the sagittal scan, you can actually start seeing small haziness over here in the bony picture. That is actually the wall of the left frontal sinus. So this is actually the left frontal sinus, and this is a patient's right frontal sinus. And this cell in the middle over here is nothing but the interfrontal sinus septal cell. Now this was a very unique case for me because when I had to read the CT scan twice or thrice, I understood that it is not the type 4 Kuhn cell, but it is actually a huge interfrontal sinus septal cell which is actually opening on the left frontal recess. It is not opening in the right, but it is actually opening in the left frontal recess, which I'll show you in some time. So if I keep on going behind posteriorly, you can actually see the left frontal sinus is completely lateralized. That left frontal sinus is completely lateralized over here, and this interfrontal sinus septal cell is actually opening up here in the left frontal recess. If I still keep on going posteriorly, you can actually see that it actually opened up on the left interfrontal sinus cell, the left recess, the left frontal recess. So this is how I came up with the conclusion that it has to be the interfrontal sinus septal cell, because had this been the type 4 Kuhn cell, okay, had this been the type 4 Kuhn cell, now here lies the importance of actually the sagittal section, because if on the sagittal section had this been a Kuhn type 4 cell, this would have never had a attachment on the posterior skull base, or you can say the posterior table of the frontal sinus, because normally the posterior ethmoidal group of cells or the frontobular cell will have an attachment on the skull base mostly. So but this is a huge cell, and it is actually having a separate definite margin over here on the anterior table. So that makes me think that this should be not the anterior group, but it could be the interfrontal sinus septal cell, which is actually opening up into the left frontal recess. Now, the second differential diagnosis for me was the frontobular cell, but as you can see on the sagittal scan over here, if I'm coming towards it, the origin of the frontobular cell should have been over here somewhere above, superior to the bular region. So for that, it had to be a first suprabular cell and then having an extension completely in the frontal sinus. So that same thing is not the case over here, because you can actually see that cell is actually isolated inside the frontal sinus and nowhere else has an extension over there. So it has to be a case of a pure interfrontal sinus septal cell. So that was the importance of the sagittal scan in differentiating out the presence of frontobular cell or the type 4 Kuhn cells, because normally a type 4 Kuhn cell will be anteriorly placed and would not be having a attachment to the skull base, unless if it's a very huge one. It definitely doesn't have an attachment, and you can clearly see a separate margin, a bony margin over here, the area of thin black line over here, that suggests that it is different from the anterior wall and having a definite attachment to the posterior skull base. So the only thing which remains is, because on the coronal section it suggests that it drains completely into the frontal recess on the left side, pushing the left frontal extremely laterally, and that is the indication of the sagittal and the coronal. And then if we keep on going posteriorly on the coronal section, we can actually see that this extension over here is actually the supraorbital cell over here. So this is not the frontal sinus, but the supraorbital cell. So you can actually see that on the sagittal scan. If I can just if I can shift this axis over here, that is the area now exactly where I've kept the cursor on the supraorbital cell, and that can be seen exactly on this section. Now, this is definitely not the frontal sinus, because the frontal sinus somewhere here drains into the frontal recess. Now, this is way posteriorly and above the orbit, and you can clearly see that this is the supraorbital cell. Okay, so the supraorbital cell is also a kind of a posteriorly placed cell behind the frontal sinus. So if I move my sagittal scan of the patient, you can actually see the different location of the frontal sinus. Now, this was my frontal sinus over here, right? And this was the area of the frontal recess. But this was the area where my cell was for the supraorbital cell. So this is my supraorbital cell and not the frontal sinus. This is a huge mistake which some people make in confusing these two as the same. So I think here lies again the importance of the sagittal section. Now, moving on further behind, we need to also understand the anatomy of the orbit. Now, if I place my cursor over here at the very center of the orbit, say for example on the right side, we can actually study the orbital anatomy as well. Now, if I go from the midline towards the right side of the patient, we can actually see on the coronal section, we can start seeing the anterior ethmoidal artery. Now, if we can just closely look at this area, this is the area of the anterior ethmoidal artery over here. Now, I've told you this many times in my previous lectures, how you can actually locate a anterior ethmoidal artery on the coronal section, but it's very difficult to understand the sagittal section. So what I'm going to do here is, as you can see over here, this is the medial rectus muscle, and over here you can see the superior oblique muscle. In between the two, or where these two muscles are having a confluence, that's the area of the anterior ethmoidal artery. So if I'm coming from the most anterior aspect like this, and I'm keeping going behind, and I start seeing the medial rectus and the superior oblique, slowly I'll start seeing a conical projection here. As you can see, if I can zoom this for you guys, you can actually start seeing a conical projection over here. This is the actual canal in which the anterior ethmoidal artery runs from the orbit into the center midline, and then gives a branch as the anterior falcine artery, and then it further goes into the nose. anteriorly, and again it goes in the dorsum of the nose. Okay, so this is how the anatomy of the AEA stands for. So this exact thing, if I keep my cursor over here, now that's the exact location of the anterior ethmoidal artery on the coronal section. The same thing I can see exactly on the sagittal section as well. So if I keep coming from the midline, I can actually start seeing the anterior ethmoidal artery somewhere over here. Okay, so that's the area where you can actually see the anterior ethmoidal artery. Now, the anterior ethmoidal artery, you can see a pinpoint over here, because on the sagittal scan, it is just going to be visible as a small opening throughout, because it's a horizontal artery. And on the sagittal scan, which is itself horizontal, we will just see a pinpoint opening of the artery. So what you can see over here, you can follow my white cursor. You can see a small hole, or you can see a small circular thing over here. This is the anterior ethmoidal artery, and you can very well appreciate that this anterior ethmoidal artery is only few millimeters from the skull base. If I can show you the measurements for it. So as you can see over here, I drew a line from the anterior ethmoidal artery level to the level of skull base, which you can actually see. This is just a reference of how you can just draw a line from a point A to point B. Now forget about this, but take a close look at this one. Is that from the level of the anterior ethmoidal artery on the sagittal scan and the level to the skull base, we can see it's only a matter of 4 mm. So whenever you are encountering the anterior ethmoidal artery, remember that you are very close to the skull base as well. This is the importance of sagittal section. So if the same thing I can do over here is that I can actually draw a line from here, and it roughly corresponds to the same thing over here. So this is the area of the anterior ethmoidal artery. If I can keep on going, this is the area of the artery over here. So it is roughly the same thing over here, which is around 4 mm. So that's the importance of the coronal and the sagittal as well. Now if I can just remove this calculations from over here. So the next important thing is to look for the area of the anterior ethmoids, the ground lamella, which is a part of the middle turbinate, which separates the anterior ethmoids from the posterior ethmoids. And behind we have the posterior ethmoids over here, and behind that we have the sphenoid sinus over here. So the pneumatization of the sphenoid bone, whether it is precellar, cellar, postcellar, conchal, we need, and we can only understand that mostly well efficiently on the sagittal scan. Not so much on the coronal scan, but on the sagittal scan we can study that very, very efficiently. So that is one more important. So I'm going to show you the level of each and every lamella, which is the anterior ethmoids, the ground lamella, the posterior ethmoids, the anterior wall of sphenoid as well. So to study the anatomy of the anterior ethmoids, I need to locate the anterior ethmoids first on the coronal section. Now, as we all know, first we locate the anterior ethmoidal artery. Now, it is said that on the anatomy, the anterior ethmoidal artery is exactly in front, few millimeters front of the ground lamella, which is the basal lamella. So the moment you see the anterior ethmoidal artery, the most posterior aspect of it, exactly at that level will be the ground lamella. That is one way of finding it, and the other way of finding it is that you need to locate the middle turbinate from the very beginning. Okay, so if I keep coming on the most anterior aspect over here, okay, just wait a second, let me change the setting over here. So somewhere around here, if we go to the most anterior aspect of the patient's coronal CT scan, and you can start going behind, then the first thing you see here is the inferior turbinate, and keep on following posteriorly, we'll start seeing the middle turbinate over here. Now, the middle turbinate has got 3 parts, the anterior, middle, and the posterior 1/3. Now, the anterior 1/3 is present in the anterior half. The middle 1/3 is basically called as the ground lamella or the basal lamella, and the posterior 1/3 is the most posterior aspect. Now, you have to remember the orientation of these 3. Which we need to know. Now, the most anterior one is present in the sagittal section or the sagittal plane. The middle 1/3, which is the The ground lamella is actually present in the coronal plane, and the most posterior aspect, which is the posterior 1/3, is present in an axial plane. So we need to remember that point. So this is how you identify the middle turbinate attached to skull base over here. The anterior 1/3 is always attached to the skull base. The middle 1/3 is attached to the lamina papyracea over here, and the posterior 1/3 is attached to the perpendicular plate of palatine or the roof of the choana. Okay, so the moment till the time the middle turbinate is attached to skull base, it will be the anterior 1/3, and the moment it turns laterally, as you can see over here, it is still attached to the skull base over here. The moment it turns laterally to have an attachment on the anterior aspect of the lamina papyracea, that becomes the ground lamella over here. So you just have to follow this middle turbinate. As you can see over here, it is trying to have a lateral turn in the direction almost at the level of the anterior ethmoidal artery. So just behind the level of the anterior ethmoidal artery, you can see that this middle turbinate is having an attachment on the lamina papyracea, which is a medial orbital wall over here, and behind which you cannot see any further. Okay, so that's the area of the ground lamella. So this exactly I'm going to pinpoint at the level of the ground lamella over here, and this exactly, which you can see on the sagittal scan, that's the area of the ground lamella. So anything anterior to this is always the anterior ethmoids, and anything which is posterior to it is always the posterior ethmoids. So that is one thing which you can do easily on the sagittal scan by having a knowledge of the coronal section as well. So if we keep on going posteriorly in this region over here, so this becomes the posterior most aspect. Now, this was the area of the anterior ethmoidal artery, and exactly behind was the area of the ground lamella. Now, behind the ground lamella, you can see a lot of posterior ethmoidal cells, and the skull base will start becoming flat. Now, unlike the skull base in the anterior ethmoids, it was completely oblique at a particular angle to the lamina papyracea. But as we cross the ground lamella behind, these flat. That means the posterior ethmoids, the skull base is actually almost flat and horizontal, and that is an indication of the posterior ethmoids, along with the fact that the posterior ethmoidal cells are larger and fewer in number as compared to the anterior ethmoidal cells, which are small in size but quite large in number. Okay, so this is how you differentiate all these points all together on the sagittal scan as well. So let me show you. This is the area of the posterior ethmoidal cells, and if I keep that over here, you can actually see that this is exactly located in the center of the posterior ethmoidal group of cells over here. Okay, and exactly behind that will be the anterior wall of sphenoid, as you can see over here, and then you can enter the sphenoid sinus proper. And this is the sella turcica over here in the midline. That's the pituitary gland over here. That's the process, the three clinoid processes which you can see over here. One of them, this is the middle clinoid process, and the anterior becomes the anterior clinoid process over here. Okay, so actually this is the clivus bone over here. So this becomes the posterior clinoid process. Here somewhere becomes the anterior clinoid process, and somewhere below will be the middle clinoid process over here. Now I've shown this in 3D anatomy in my previous lecture as well. So this is the clivus bone of the sphenoid, and we can have the cervical vertebrae over here. So this is the maxillary bone, and that's the socket for the mandibular bone. This is basic sinus anatomy you can locate on the sagittal scan. That's the patient's choana, and that's the patient's nasopharynx, which has a soft palate over here. You can see actually the soft palate, which you can see the ridge which differentiates the oropharynx with the nasopharynx over here. So this is the anatomy which you can see on the sagittal section altogether. So if we keep on going posteriorly on the coronal section, you can actually enter into the sphenoid sinus, and on the sagittal scan, this is the sphenoid sinus which you have entered right now. And that's the right sphenoid. You can see we are actually in the right sphenoid, and that's the dominant sphenoid for the patient. And you can see over here, that's the anterior clinoid process which we always study. So if I keep this marker over here, Now, as you can actually see, this is the area of the anterior clinoid process, and this is the area of the optic nerve. So if I can pinpoint this area, now my cursor, that's the area of the optic nerve. So on the sagittal scan, the optic nerve will be exactly above the sphenoid anterior wall. Okay, as you can see over here, and if you can trace that posteriorly, it will keep on going posteriorly, as I'm doing here right now. It can keep on going posteriorly. That's the area or the level of the optic nerve, and posteriorly this should be approximately the rough area of the optic chiasm over here, and this is the area of the optic chiasm over here. So that's the most posterior aspect of the sphenoid. And if you keep on going behind, that's entirely the clivus bone over here. And if we keep on going posteriorly, there will be the brainstem will come over here, the vertebral artery will come over here, and so on, which we can study on the MR angiography or the MRI scans. So I can do that for you in my next lectures if you want. I can teach again the cerebral vasculature right from the neck up to the brain, which I've done so in my previous lectures, so you can go and check it out. So this is the basic importance of how you can use the sagittal scans for studying the anatomy of the sinus and the nasal and the orbital anatomy as well. So if you guys have any extra points which you have which is very much relevant to the study, you can let me know in the comment section below, because for me these are the points which are really important for a surgeon's point of view. Whatever points you think I have missed out, you can let me know in the comment section below, and I'll definitely give a check into it. Okay, so I hope the concept of the sagittal scan is very much clear for you guys right now, or the frontal sinus anatomy, the anterior, the posterior ethmoids, the ground lamella, the sphenoid, the pituitary, the processes. Okay, so this is how you can actually study the area. This should be the area of the posterior clinoid process somehow, because that is posterior to the sella turcica around here. So that's the area of the choana for you guys. As I said, that's the nasopharynx, and that's the oropharynx around here. I think that's it. So I hope the sagittal scan basic anatomy is very much clear for you right now. And in the next lecture, I'll do the same thing with the axial scan. Now the axial scan has got its own different importance, which I'll be talking in very much detail in my next lecture. So till then, guys, be safe and keep checking out my videos to learn more basic stuff around ENT and skull base and neurosurgery as well. So till then, take care, guys. Thank you.